Okay, if I could have your attention, we'll go ahead and get started. Hello, we're going to go ahead and get started. Welcome to today's Flexner Discovery Lecture Series. Today's theme is Vanderbilt's Discovery and Vanderbilt's Cutting Edge. The talks that are going to be presented today were presented to Vanderbilt's, to the Medical Center's Bioscience Advisory Board as a representation of the kind of excellent work that we do here. The group was so impressed by these talks, they wondered, do we present this information to our own faculty and staff? And we said, well, we do in one way or another, but they suggested that we make it a very prominent part of what we do each year. So we've added these into the Discovery Lecture Series. We have 3 action-packed talks today to be given by the group shown on this slide here. The first presenter will be Zheng. And he came to Vanderbilt in 2000. He's currently the Ingram Professor of Cancer Research and Professor and Chief of Division of Epidemiology in the Department of Medicine. He's the Director of the Vanderbilt Epidemiology Center, co-leader of the Vanderbilt Ingram Cancer Center's Epidemiology Program. He's an NCI Merit Award holder and an elected member of the American Epidemiological Society, and he regularly serves on grant panel reviews for NIH and other funding agencies. And he's on multiple editorial boards for epidemiology and cancer. And Dr. Zheng will present Large Epidemiological Studies, a Valuable Population, and Laboratories for Scientific Discovery. Wade?
So thank you for the introduction, and also good afternoon. Thank you for coming to this talk. Can you hear me from the back? Okay. So I feel very honored to give a talk in this lecture series, and I also feel very honored to share this podium with 2 distinguished colleagues. So today I'm going to talk about several large epidemiological studies and provide some examples to show that they are valuable population laboratory for scientific discovery. So most of our work has been in the area of non-communicable diseases. Here are some data from the 2011 UN Summit. About 36 million deaths worldwide in 2008 due to NCD, and about 80% of these in developing countries. And this number will continue to increase in the coming years very rapidly. And in this country, African Americans experience a higher mortality than European Americans. And we know that the key to reduce mortality is to prevent disease from occurrence. This is a quote from Benjamin Franklin: "An ounce of prevention is worth a pound of cure." And a similar concept was proposed about 2,000 years ago in Chinese medicine. This is 上医治未病, superior doctor treat unknown disease. So I'm not going to translate this to you because that will make my clinician colleagues feel uncomfortable. But you can go to Google and find the translation. So, to prevent disease, we need to identify risk factors and also disease predictors. So, the large prospective study are very strong and cost-effective study design for this purpose. But at this point, most of the existing cohort studies are conducted in European descendants, and very few in other populations. And the result from this study may not necessarily generalizable to other populations, such as African American and then those living in developing countries. So over the past 18 years, we have devoted substantial effort and established these 3 large prospective studies, 2 in Shanghai with about 136,000 people, and 1 in this country we call Southern Community Cohort Study, in the 12 southeast states in a low-income population, 2/3 African American. So these are very unique cohorts, and they allow us to test many hypotheses that are difficult to investigate in other populations. So here are some examples of other large studies conducted by Vanderbilt investigators. So today, I'm going to talk about Shanghai studies to show the value of conducting international studies in scientific discovery. So using the resource from Shanghai studies, about 55 or more studies have been using the resource from Shanghai study, externally funded by Vanderbilt investigators, and about same number of studies led by outside investigators. So at Vanderbilt, we have studies about asthma and coronary heart disease, colorectal cancer, stroke. And this is a training program, and this is career development award by a junior investigator, lung cancer, gastric cancer, and several breast cancer study. And we also have study on Parkinson's disease, type 2 diabetes, bone fracture, those kind of things. So today, I'm going to talk about these three studies, three all breast cancer study. So in particularly, I'm going to talk about the association of soy food intake and breast cancer survival, and talk about two novel loci identified in our study for breast cancer risk. So as many of you know, that soy may have some potential health benefit, and there's certainly a lot of interest in the news media, and as I show here. But at this point, most of the data are from animal experiments or in vitro experiments. And results from human study have been very few and inconsistent. And we know that we cannot extrapolate data from in vitro and animal data to human. The reason not many study in soy food is the soy food intake in this country and in European population is relatively low. So the study in this population are not very informative. So soy food have high level of isoflavones. They are phytoestrogens. They have a similar chemical structure as endogenous 17-beta estradiol. So you can see this structure, but they are much less potent compared to endogenous estrogens. So they can bind comparatively estrogen receptor and to reduce the signal transduction. And they can increase SHBG synthesis and inhibit aromatase. So they have this anti-estrogenic effect, which potentially can be beneficial for breast cancer survivors. So they also, as I mentioned earlier, they can bind to estrogen receptor. So they may have estrogenic effect, particularly when endogenous estrogen level is low, such as in breast cancer patients, they receive anti-estrogenic therapies. So there's also some data show that there may be some interaction between tamoxifen and isoflavones, and also in vitro study, animal studies show that isoflavones may increase cell proliferation and also increase the growth of tumor. So soy food has been widely distributed in many foods. So this has been a concern for many breast cancer survivors and also their healthcare providers. So they don't know, whether they should take soy food, and they need to be careful about their diet or not. So to address this concern and also test some other study hypotheses, so we started a project recruited in 2002, recruited about 5,000 patients. And this study was led by Xiao Xu. So we did in-person interviews, collect biological samples and medical chart, and follow up patients multiple times after cancer diagnosis. So this is a major strength of this study because most of other study only obtain exposure data at one time baseline. So we did multiple times interview. We did multivariate analysis, and then about 50 papers from this study have been published. So using the data from these studies, we find that soy food intake was related to a reduced risk of total mortality. So here we divided patients into these four groups based on the quartile distribution. So it's a low intake to high intake. So among those with high intake, there's about 30% reduction in total mortality among breast cancer survivors. We find a similar pattern of the association if we use this as a outcome, breast cancer recurrence and breast cancer specific mortality. So as I mentioned earlier, that there's in vitro data show potential interaction of tamoxifen with soy isoflavone. So we test this hypothesis in human, and here is the tamoxifen use, never used, and ever used, and the soy food intake level. So you can see from this graph that tamoxifen use is related to a reduced mortality in this population. And also, doesn't matter when they take tamoxifen, there's a reduced risk of mortality with increased intake of soy protein in this cohort. So it's interesting is that you can see that among those with high soy food intake, actually the risk is about the same. So this is about 40% reduction in risk. So to evaluate whether that association, which we find in Chinese population, can be generalizable to American population. So we did a pooling project. This project was led by Sarah Nectar and also Xiao Xu. This includes about 9,500 patients, including 2 studies from California. And you can see that the intake level is quite different. In Chinese population, it's about 45.9 milligram per day of isoflavone, and in American population, it's about 3.2. But even with such a low dose of intake, we still see dose-response relationship. So high intake of soy isoflavone related to reduced mortality. So to answer the question, whether the inverse association of soy food intake and mortality is due to anti-angiogenic effect of soy isoflavone. So look at 2 outcomes. One is the hot flash, another is osteoporosis. So here we compare high quartile intake with lowest quartile intake. And we see an increased risk among premenopausal women, particularly with high intake of soy food related to hot flash. And also we found the same thing that for osteoporosis, high intake of soy protein related to increased risk of osteoporosis, particularly among postmenopausal women. So largely due to the results from our studies, so the American Cancer Society modified the guidelines for cancer survivors. And the American Institute for Cancer Research concluded that soy food is safe for breast cancer survivors. So we are very happy that our results actually make a difference in the national guidelines for cancer survivors. So in the next few minutes, I'm going to talk about genetic factors for breast cancer. So as you know that this family history of breast cancer is one of the most consistently identified risk factors for breast cancer. And there are about 10 high penetrance or moderate penetrance genes have been identified for breast cancer risk. But the mutation, germline mutation of these genes are uncommon, very rare in the general population. So mutation of these genes actually explain only about 5% of the cases in the general population. So it has been hypothesized that these low penetrance but common genetic variants may explain a large proportion of cases in the general population. So over the past about 25 years, about 300 variants have been implicated in this kind of candidate gene study related to breast cancer risk. And recently, we did a very comprehensive meta-analysis and published in Lancet Oncology. And then we found that only a very few of these variants can be replicated, which means most of these findings are false positive because of problem of study design or not replication, multiple comparison. So in 2005, the genome-wide association study emerged as a very promising approach to study common genetic variants for complex trait like breast cancer. So I'm aware of the paper. Actually, the first paper was published in Science for age related macular degeneration. So there was a paper, and actually in the same issue, there's another paper from Vanderbilt using linkage analysis, also find the same variants related to AMD. So we didn't know there was a study at that time in 2005. So we did our own pilot study in 2005 using this beta testing chip, Affymetrix, 500,000 variants. We need to evaluate the feasibility. So in the past, nobody actually look at variants, in such a large number. So usually we look at like 10 or 20. So we need to look at the feasibility of the study, so we're not experienced. We also want to conduct a proof of principle analysis to see whether we can find the needle in a haystack. So we launched the full-scale study in 2008. Now this consortium includes about 60,000 cases and controls from over 20 studies in multiple Asian countries, and also in this country from Hawaii and California, Asian Americans. So we identified about 15 novel loci and variants, making our study the second most productive GWAS in this cancer in terms of number identified, variants identified so far. So we have expanded this consortium to other traits, including colorectal cancer. Actually, colorectal cancer GWAS now produce, actually it's more productive than breast cancer, but I don't have time to talk about it today. So this is the first locus we identified using the GWAS in Asian population. This is located in 6q25. It's near the estrogen receptor alpha gene, ESR1 gene. So this is the discovery stage. We use about 500,000 variants, scan the whole genome, find a variant related to increased risk of breast cancer. This is the heterozygous from the variant type, homozygous from the variant type. This is odds ratio. This means about 50% excess risk of breast cancer compared to homozygous with the common genetic variant. Very small p-value, and we replicate it in 2 studies, and this is very small p-value. Next, we look at this association by estrogen receptor status. So we found that association was stronger among ER-negative breast cancer. So this is actually the first genetic locus identified for ER-negative breast cancer, and we know that the prognosis for this cancer is quite poor. So after that, we actually that work was done in Chinese population, so we want to look at in other Asian population, in like Japanese, other Chinese population, European population, and African American population. So we see that association was quite consistent in Asian population, that's Chinese and Japanese, and some association in European population, but it's quite weak. And there's no association in African American. So this suggests that this is not a causal variant. If that is a causal variant, you will see consistent association in all 3 populations. So in order to identify causal variant, so we conducted some functional analysis. This work was led by Chu-Yin Tsai. We did some work in these 30K regions, 30K KB regions between this open reading frame and the ESR1 genes. And we analyzed 3 SNPs and identified 1 SNP potential functional. And we then go back to the population to see whether this SNP is related to breast cancer risk in the population. And indeed, this SNP related to breast cancer risk. So in this study, we started with the discovery from the population, the previous slide, and we did a generalizability study, and then we do the function analysis and come back to the population. So we kind of complete the full cycle. So we also conducted the first GWAS of structural variants. So structural variants explain more interpersonal variability in the genome than these single nucleotide variants. And the structural variants are more likely to be functional. But most of the study, pretty much all the study conducted so far, so they look at that single nucleotide variants GWAS because this is relatively easy to do. And structure variant GWAS is much more difficult to do. So it has been hypothesized that structure variants may explain some of the missing heritability after GWAS of structure of the GWAS of SNVs. So this is a two-stage studies led by Zheng Lang. So in the first stage, we used 1.8 million probes, scan the whole genome, and identify promising variants for replication. And we identify a common deletion in APOBAC3 genes related to breast cancer risk. This is a very strong association. Anybody doing GWAS, you don't see this kind of strong association. Actually, this is one of the strongest loci, risk loci identified for breast cancer. So this is no deletion as a reference, and two deletion, there's about close to 80% excess risk of breast cancer. So there's an interesting distribution, population, and the frequency of the deletion in the population. So in Africa, the deletion is about 1%, less than 1%, is very uncommon. And then in European population, it's about 10%. And in East Asian population, it's about 35 to 40%. In Oceanic population, it's about 90%. So the study in Asian population is very powerful statistically to identify these locus. So we did a study to look at whether this SNP also related to breast cancer risk in European population. And this is the study we used, the National Breast Health Study, and analyzed about 3,200 cases and controls. And the allele frequency deletion is similar to the outside data, is about 10%. And indeed, there was an association. And now, one of our postdoc fellow, Ryan Delahanty, using BioView data, also replicate this association. So what's the impact of epidemiological studies? So we identify 30 novel loci, reveal multiple novel biological pathways. So hopefully some of these pathways, the genes can be targeted for drug, in the novel drug in the future. And we show that genetic factors are strongest predictors for cancer risk. And I show some examples that the nutrition study provides scientific evidence for lifestyle modification to reduce cancer risk and mortality. So in conclusion, we have established multiple large epidemiological studies. We use this study as a valuable population laboratories for scientific discovery. And the value of this study will continue to rise as we identify more cases in these cohorts. So this is acknowledgement. I'd like to thank my colleagues, collaborators in multiple institutions. Some of our papers include 200 authors, so I cannot include everybody's name here. So certainly study staff and participants for their contribution. Our work would not be possible without their support, and NIH for funding, and also other funding agencies. So thank you very much for your attention. So I'd be happy to answer your questions.
Questions for Dr. Zheng?
So with the APOBAC-C3AB, are you suggesting that that's a tumor suppressor then?
So there are some work published recently show that overexpression of APOBAC3 several genes actually related to more mutation in the genome. So it's interesting. We find the deletion in the germline, and other people find in somatic actually overexpression. So that creates a paradox. So we try to address that issues. Is the tumor suppressors, or it seems in the germline, in the somatic, it's not tumor suppressors. Actually, Ryan just submitted a paper to PROS Genetics. We try to link the germline deletion to somatic changes to see what's the correlation.
Because it's thought that it may be one means of a host warding off HIV infection in terms of just creating mutation against HIV and triplets.
Yeah, I mean, these set of genes are important for immune response to defend the invasion of parasites or bacteria or virus genome. Yeah, actually, several years ago, I was at Hutch, and they are very experienced in doing clinical trial. We discussed about the possibility of doing a trial, clinical trial among breast cancer survivors to more definitively test the hypothesis. And you see that ACS guidelines is safe, it's okay, right? It's not that you need to increase the intake. Yeah, so it's a good point. Yeah. Mm-hmm.
Okay. Thank you very much.
Okay, good.
Okay, our next presentation will be from Marie Griffin, who joined the faculty here in 1985. She serves as professor of health policy in the Department of Medicine. She co-founded Vanderbilt's Masters in Public Health program and currently directs the epidemiology track as well as the public health practicum. She served on the CDC's Advisory Committee on Immunization Practices and was a member of the Institute of Medicine's First Committee on Vaccine Safety. She served on the FDA's Non-Prescription Drug Advisory Committee, AHRQ's study section for health services research training awards, and she's received Vanderbilt Faculty Mentoring and Teaching Awards, recognition from AHRQ for outstanding achievement in healthcare policy research, and she's been elected to the American Epidemiological Society as well as the American Academy of Physicians. Marie will talk about vaccine-preventable diseases, influenza, and pneumonia.
Could I save it? Okay, let's see. I got it. Okay. Oh no. Okay, let's see. I heard yours so many times I probably could do it. Okay. Hopefully you can hear me. Great. I'm really happy to be here and honored to be here today to talk to you about some studies we've done using large databases to study vaccine-preventable diseases. I'm going to talk about influenza and pneumonia and start with some studies on influenza burden of disease. And so this picture you see is not uncommon today, seeing a young, healthy person being vaccinated against influenza. However, it wasn't that way in the 1990s when influenza vaccine was only recommended for people at high risk for having complications of influenza. And I was serving on the CDC's Advisory Committee on Immunization Practices at that time, and we were asked to, whether we should make a recommendation for pregnant women to be vaccinated with influenza vaccine. So I was a little bit surprised by the state of our knowledge about influenza and pregnancy, and we really had to go back to the influenza pandemics of 1918 and 1957 to really get almost any published literature on influenza and pregnancy. This is a 1919 JAMA article, 1,350 pregnant women. The mortality with influenza, as a case series, the mortality was 27%. So there were challenges to advancing influenza vaccine policy at that time. The recommendations were intended to prevent serious morbidity and mortality, yet deaths and hospitalizations are relatively rare. And there are also influenza-associated illnesses difficult to identify. It's not easily distinguishable from other respiratory illnesses. The standard of diagnosis at that time was viral culture, which is slow. It was not clinically useful. So, however, for years, the Centers for Disease Control had been using these surfling models to estimate yearly mortality from influenza. So let's see. These are the percent of percent of all deaths that are due to pneumonia and influenza. And these are the models. This bottom line, the black line here, is the modeled seasonal percent of deaths from pneumonia and influenza, as you can see, in the wintertime, they're higher. And then they set this epidemic threshold, which is sort of like when the observed deaths go above this threshold, something weird is happening. And that only happens when influenza is circulating. So that you can see these red lines are the observed percent of deaths due to pneumonia and influenza. And this happens, these goes above this epidemic threshold when we have a bad flu season. And it's by this means that we estimate the number of deaths every year that are due to flu. So we decided we would do something relatively simple, a very simple model where we could estimate to understand how many hospitalizations were due to flu. So we have this model where we could calculate hospitalizations in the summer and in the winter time when flu wasn't circulating and when it was circulating. And this excess in hospitalizations that we expected to see when flu was circulating would be how we would calculate influenza-associated hospitalizations. So I had been working with Tennessee Medicaid data for a while, and we had 19 years of data. We were able to identify women of childbearing age, and we could identify all cardiopulmonary hospital discharges. We could link women to birth certificates using maternal identifiers, and thus identify women who were pregnant and the timing of pregnancy. We also had access to the Vanderbilt vaccine clinic, and those investigators in pediatric infectious diseases did respiratory viral surveillance on children every year during this whole period. And so we knew when influenza was in our community. So this is the first study we did using these models of influenza hospitalization and pregnancy. We were able to identify 1.4 million women. 15% of them were pregnant. We identified over 4,000 cardiopulmonary hospitalizations. And we compared rates of cardiopulmonary hospitalizations in pregnant women compared to healthy non-pregnant women. And what we found was that as pregnancy progresses, this is timing of pregnancy into the third trimester, the risk of having a cardiopulmonary hospitalization compared to non-pregnant women increased. So it was about 2 to 5-fold higher in pregnant women. And then we used the model that I explained, subtracting rates of these hospitalizations in the winter when flu was not circulating from rates when flu was circulating to actually estimate the actual hospitalization rates in non-pregnant women and during the first, second, and third trimester. And so we estimated that every year about 1 to 2 there were 1 to 2 influenza-associated hospitalization per 1,000 women who were pregnant during the influenza season. So we also use similar models to look at the burden of influenza in children. And these graphs show you rates of outpatient visits and antibiotic prescriptions in the wintertime when flu was circulating and when it was not circulating. And you can see that for every age group, starting from less than 6 months to older children, the rates of these outcomes were always higher when influenza was circulating. It could circulate in November and December or January and February, but these rates were always higher when flu circulated. So again, using these models, we could estimate that hospitalizations were relatively high in young children, and that 7 to 14% of children every year had an outpatient visit for flu, and about 3 to 8% received an antibiotic prescription. And the editorial that accompanied this article said, well, sort of like, that's a great study, but can we really make policy based on these types of modeled data where we're not really measuring flu directly? So this was the impetus for CDC to fund the new vaccine surveillance network. And this network has now been going on for over 15 years, but the first 10 years was devoted mainly to trying to establish the burden of influenza in young children. And we participated in this study, enrolled children less than 5 years of age who had respiratory symptoms, by this time we're using RT-PCR, a very sensitive and specific test for influenza. And we estimated that there were about 1 in 1,000 children under 5 was hospitalized for flu every year, that about 5 to 9% of children had an outpatient visit for flu every year, and that 1 to 2% had an emergency department visit for influenza every year. And these types of studies and others helped really inform our vaccine policy. In 1996, vaccine was recommended for pregnant women, and between 2005 and 2010, the recommendations for influenza vaccine use was gradually expanded, and until now we have in the U.S. universal recommendations for vaccination, and you can see our Vanderbilt Flu-a-Palooza there. I'm going to now move on to talk about our studies on pneumococcal pneumonia, trying to measure the impact of a new vaccine on pneumonia. Pneumococcal pneumonia is important because it is estimated to cause about 30 to 60% of all community-acquired pneumonias in both children and adults. And in the developing world, it's a very important cause of under 5 mortality. So the 7-valent pneumococcal conjugate vaccine was developed to target 7 of the 90 serotypes. These 7 serotypes caused most invasive pneumococcal disease, which is at the top of this triangle. So the Streptococcus pneumonia, the bacteria, causes a lot of different diseases, and these are perhaps the most lethal. And this vaccine was developed to prevent these diseases in young children. There was a randomized controlled clinical trial in 38,000 infants that showed the vaccine was 97% effective in reducing invasive pneumococcal disease due to the vaccine serotypes. So before we go on further, I want to tell you how people get invasive pneumococcal disease. So the step before you get meningitis or bacteremia is one has to be colonized with the pneumococcus in the nasopharynx. And this is really the root to all pneumococcal disease, to meningitis, osteomyelitis, pneumonia, bacteremia, and otitis media. And also we know that children are very heavily colonized compared to adults. And so that the thought was if we can reduce colonization with the pneumococcus, we can reduce all the diseases and also perhaps reduce transfer of bacteria from children to their parents and grandparents. So when this vaccine was licensed and recommended for all infants in the year 2000, there was still a lot we didn't know about the vaccine. What would be the effectiveness in the real world? There was concern about what's called serotype replacement. So this vaccine was going to affect 7 common serotypes, but would other serotypes become more common and start causing more disease? Would there be indirect vaccine effectiveness? We didn't really know if it would reduce or eliminate colonization and then have effects in older children than adults. And then the vaccine effectiveness against pneumonia was really unknown. This was a secondary endpoint in the clinical trial. The endpoint was all clinical pneumonias, and the decline was not statistically significant, so pneumonia was not in the vaccine's licensed indication. So there were challenges to studying the effect on pneumonia because there's really no feasible way to determine which pneumonias are pneumococcus. So we decided we needed to assess all-cause pneumonia. It's a non-specific outcome, but if the pneumococcus really caused 30 to 60% of pneumonias, we should see an effect on all-cause pneumonia. So just to start with, I want to show you what happened with invasive pneumococcal disease. So the vaccine was introduced in 2000. These are the rates of invasive pneumococcal disease pre-vaccine, and then very quickly, invasive pneumococcal disease declined remarkably. And so by 2003, vaccine type, invasive pneumococcal disease, had declined 94% in children less than 5, and also 62% in older children and adults, indicating that there was an effect on colonization and there were indirect effects on the rest of the population. And these data are from CDC's active bacterial core surveillance, which Vanderbilt has participated in for years and years. But we were interested in the national impact of PCV7 on pneumonia hospitalizations. So for this analysis, we decided to use the nationwide inpatient sample, which is a 20% sample of all U.S. discharges. And we were able to calculate all-cause pneumonia rates using the NIS, the sample, and census data for denominators. We conducted a time series analysis to look at the change in rates from 1998 to 2004. So this slide shows monthly annualized pneumonia hospitalization rates in children less than 2. That's what the green dots are, and you can see this nice seasonal curve. And we fit a linear estimate to the rates prior to vaccine introduction, and this is pretty stable, pneumonia rates prior to vaccine introduction. We extended this line to say this is what we would expect the rates to be if there was no change. And then we fit a line to what happened after vaccine introduction. And this represents a 39% decline in pneumonia hospitalizations in children less than 2. We chose a control condition, dehydration, and found no change in these hospitalizations in children less than 2. And we did see a decline in pneumonia hospitalizations in most other age groups, but they weren't statistically significant. So in 2010, a new vaccine was introduced, PCV13. This was an expanded vaccine. But we thought we had an opportunity to look at the whole 10 years that PCV7 was being used to see what was the impact during that 10-year period. So again, we used NIS data. And we found that the decline that we observed in 2004 in children was maintained and actually went a little lower. So there was a 43% decline in pneumonia hospitalizations in young children. And the annual decline in all children by 2009 represented about 56,000 fewer hospitalizations and 116 fewer deaths annually due to the vaccine. Now, when we looked at adults, we saw the decline took a longer time to manifest, but by 2009, there was a 10% decline in pneumonia hospitalizations in adults. And because pneumonia hospitalizations are so high in adults 75 years and older, this decline represented 112,000 hospitalizations and 13,600 deaths a year fewer since this vaccine was introduced. We've just are working on what happened since PCV13 was introduced. And these are data from Tennessee. These are from our hospital discharge data in Tennessee. And again, we see the same, basically the same thing that we saw in the national data. Very stable rates prior to vaccine introduction, a 40% decline associated with PCV7 introduction. But now we see another 20% decline associated with the new vaccine that adds 6 more serotypes. And so that pneumonia hospitalizations in young children are now at a historic low in Tennessee at 4 per 1,000, a 60% decline from prior to vaccine introduction. So in summary, our influenza burden studies inform the expansion of influenza vaccine recommendations in the U.S., and there's been a concomitant increase in interest in influenza vaccines, and there are new vaccines and better vaccines coming up because of the increased interest in using these vaccines. And I think we're much better prepared, hopefully, for the next influenza pandemic. The pneumococcal conjugate vaccine studies, really the U.S. has had a pretty aggressive policy. We were the first country to introduce this vaccine. And these types of studies have helped aid the introduction of this vaccine in other countries, including support by the Gates Foundation to introduce the vaccine where it's most needed in developing countries. So I just want to acknowledge and thank some collaborators on the influenza and pneumonia studies that were done here at Vanderbilt. And happy to answer any questions.
One of the depressing trends is how Hollywood celebrities can encourage thousands of parents not to vaccinate their kids with highly dysfunctional fantasies about antigen challenges and all the rest. And you have data like this that are so compelling, so dramatic, so definitive. How do we translate the messages, say your pneumococcal findings, to the general population, other than getting Bill Schaffner on television? Which is a good thing.
Yeah.
What kind of messaging do you think we can do to get this out to the lay population?
Yeah, well, I think there's two things. I mean, I think we do need to publicize this, and I think there is a very active effort in publishing the good stories, and CDC is really trying to advertise their successes. I think the other part is the vaccine safety part, which for a long time was ignored, or these people were treated like quacks and marginalized. And I think it's really important to realize the benefit that they've really done to the vaccine program, that I think to do safety studies is so important to maintain the confidence in our vaccines. And so I think that although it's hard to deal with that, luckily in the U.S. it's still a small portion of the population. And I think doing really well-done vaccine safety studies is part of the answer. Yeah.
Are there new vaccines on the horizon that are likely to be population-based vaccines?
Yeah, I think there's a lot of really exciting things coming along. I think now that we're starting to vaccinate pregnant women. So for a long time there was this fear about vaccinating pregnant women. So even if there was a recommendation, the manufacturer would still have in the label, because nobody wants to be responsible for anything that happens in pregnancy. So I think the idea of vaccinating women in pregnancy, we do this in other countries for tetanus. We're now doing it in this country for pertussis because children under 6 months are still very prone to have serious complications of pertussis, so we're trying to vaccinate moms. There's a lot of work here at Vanderbilt on other vaccines. RSV would be a great vaccine to have for both children and adults. Yeah. So there's a lot in the works. Yeah.
Any other questions? Okay, thank you very much.
Okay.
Our next speaker is John Graves, who joined the faculty at Vanderbilt in 2011. He's assistant professor of health policy and assistant professor of medicine. His research was cited in the U.S. Supreme Court's arguments over the Affordable Care Act and has been featured prominently in the national media and in state debates over the impact of Medicaid expansion into hospital finances. Dr. Graves is the recipient of fellowships and awards from the Agency for Healthcare Research and Quality, the National Institutes on Aging, National Bureau of Economic Research, American Statistical Association, and the National Academy of Social Insurance. And Dr. Graves will talk to us about optimizing the design and implementation of health policy. John?
All right. So if you haven't noticed the subtle theme running through today's talks, it's the use of large, even population-level data sources to influence discovery. And so if it wasn't obvious yet, I'm going to hit you over the head with that in my talk in the next couple minutes. So the theme of the research I'm going to highlight in my talk really is about using the rigorous and creative application of large data sources as a very powerful toolkit to move policy and achieve the triple aim of improving population health, lowering the per capita cost of care, and improving the experience of care in the United States and elsewhere. What I'm going to do is highlight 3 areas of research that I've been working on over the last 3 years since arriving at Vanderbilt with colleagues not only here but also at Harvard. And first, what I'd like to do is basically tease out a new research study that's actually coming out next month in the journal Health Affairs, where we're using big data sources. We're leveraging big data coupled with the insights from behavioral economics and psychology to think about how we can optimally design health policy in the United States. In particular, as we think about enrolling people in the private insurance expansions we're seeing under Obamacare right now. From there, I'm going to kind of shift gears a little bit and talk about a methodological toolkit we put together here, which has really aided in a few applications, which I'll highlight, in designing policy and planning for policy at a very small area. And then that's going to lead into my third topic, which is on a lot of people's minds today, which is if we're going to cover upwards of half of the uninsured, which is what the projections say, how will that coverage expansion affect not only the demand for primary care services, but the supply of primary care service providers in the United States? So we're all well aware by this point, at least, that Obamacare, the Affordable Care Act, is expanding insurance coverage to millions of otherwise uninsured people in the United States. And one of the mechanisms they used to do this was a private insurance expansion through what's known as the exchange or marketplace. So if you've been reading the news about the fact that 8 million people were signed up over the last 6 months or so, that's really this marketplace coverage that they're talking about. But there's this key question on people's minds, which is, if you build this marketplace, if you reform the insurance market for people who don't obtain insurance through an employer, will people actually sign up for coverage? And there was a lot of angst, as you might have seen in the media, about who would get covered and what their characteristics look like. So what I'd like to tease out in my remarks today on our research is that the key to optimizing enrollment in these private marketplace plans can be found in this graph right here. So despite what it looks like, I know this is probably a room full of clinicians. This is actually not a heart rhythm. Yeah, probably a good thing. What we've done is basically take 10 years of Google search data originating from the United States and look at when people during the year look out information on enrolling in health insurance. So just as you can track seasonality and when people get the flu, as Marie covered in her talk, there's also considerable seasonality in when people look for information on health insurance in the United States. And this is going to become important, I think. It'll become clear why this is important in a second. So just like we do here at Vanderbilt, the enrollment in these marketplace plans that they're expanding to the uninsured is going to happen during an annual and open enrollment period. So the open enrollment period for this first year of coverage was actually about 6 months long. It started last October and it ended at the end of March of this year, though a few people could have signed up all the way through April 15th. But starting this year, or actually next year to be more precise, open enrollment is going to occur between November 15th and January 15th. And this is going to become really important in a second. And another important feature is that most of this marketplace enrollment is going to be among low and moderate income uninsured families that are looking for coverage. And this is significant because the behavioral economics literature tells us that at least among low-income people that have a lot of constraints on them, not only in terms of their time but in terms of their resources, when people are stressed by scarcity, whether that's of income or time, they can make what many perceive to be irrational decisions. They don't enroll in health insurance or they pick a plan that's bad for them. And this research is very clear in showing that many of these annual decisions that people make can have very different outcomes. People will make a different decision on whether you allow them to make that decision at a time of plenty or a time of scarcity. So what we did in our research is take Google data and ask, well, you're going to ask people to enroll from November until January, which is roughly Thanksgiving through New Year's of every year. Just at the same time when they're starting to pay their winter heating bills, just at the same time where they have demands on them to buy gifts for travel. Basically, you might be asking them to enroll in health insurance at the absolute worst time of year. And so what we did was go to Google data to find out, well, when do people look at information on enrolling in health insurance in the United States? And it turned out that, yes, if you look at when the search volume with Google data, when it peaks and troughs during the year, it basically falls off a cliff during that gray period there, which is the open enrollment period starting next year. So this, of course, begs the question of, well, if that's the bad time of year, then when is a good time of year to have people, to open an open enrollment period for low-income people to enroll in insurance plans? And it turns out that the time of year when people are feeling kind of most financially flush is in the first half of the year. And that's because that's the time of year when people get tax refunds. So among people that are going to be eligible for these plans, the average refund is about $2,300, and about 90% of these families actually get a refund. So we're talking about a significant amount of money for low and moderate income families, and it's all basically, it all comes to them in February and March. So unlike most of us who file at the very end of the tax filing deadline right at April 15th, most low-income people actually file in February and March. So if you look at Google data on tax refunds, that's that, I don't have a pointer, but that's basically that dotted line there. That's when people are getting their tax refunds. And if you look at when people are looking for information on cash advances, when they're feeling the least financially insecure, it bottoms out there. Oh, I'm sorry. It bottoms out there right at this period of time. So what we were able to do is leverage the insights of behavioral economics in this research, along with our use of a big data source of Google search terms, to basically more optimally design when we should have people sign up for these marketplace plans. I'm going to shift gears for the next few minutes and talk about this small area toolkit that we put together for health policy. So I basically covered this earlier, but I think if you could kind of summarize the state of knowledge and thinking right now, is that we just opened enrollment for, at least up until now, about 10 million newly insured people. And, you've got Uncle Sam there at the bottom and this influx of patients. And I think these are some doctors. So basically, everyone's just kind of waiting for this influx of patients into the system, of newly insured patients, wondering how much they're going to need and what kind of resources they would need. So the problem facing us was that we actually have a wealth of national data, whether it's Census Bureau data, administrative data sources, et cetera, consumer data. There's a lot that we can say at a national level, but not much that we could previously say, at least easily, at a local level. So if we want to project out what the new demands in supply for primary care providers or other things at a local level, we really didn't have a kind of easy-to-use methodological toolkit to leverage the wealth of national level data that we have to say something more locally about what we should do. So what we did with a grant from the Robert Wood Johnson Foundation is develop a small area toolkit that practitioners in health policy can basically download and use to do small area estimates of policy impact. So basically what this toolkit allows you to do is take federal survey data, consumer data, administrative data, and even clinical data and combine it within a statistical methodology, and you can combine that with study design and economic theory to basically say something more accurate at a local level about the impact of policy. And then we are disseminating this type of information through the kind of traditional academic means, through medical and academic journals, but also through social media and policy briefs to end up with more evidence-based policy in the United States. So one example of how we did this came out in Health Affairs last fall. So if you want to understand how the new demands on care are going to change with all these people gaining insurance coverage, it really helps to understand the dynamics of how long they've been without insurance coverage. Because if you're thinking about new care that they might be seeking, there's something very different about somebody who's uninsured today but last had insurance coverage a month ago, and somebody who's uninsured today but last had coverage 5 years ago. So if you think about if they're going to seek out primary care, et cetera, you should really understand how long they've been without coverage. And so what we did in this piece of work is exactly that. We mapped out in a very local area where are the areas where there are long-term uninsured people who might be obtaining coverage and who might need more care, versus areas where spells without coverage were kind of more transitory as people were going in between jobs, where you wouldn't necessarily see huge surges in demand for primary care or specialty services. So the next logical question is, now that we have this kind of baseline of where these long uninsured spells are originating, what's the impact of a reform like what's happening under the Obamacare in terms of how that changes the dynamics of health insurance coverage? That is, by giving them access to coverage, are we shortening the amount of time that people spend uninsured in the United States? And to answer this question, which we published a couple of years ago in the New England Journal, these graphs, if they look like Kaplan-Meier curves that you probably come across in your clinical research, that's because these are Kaplan-Meier curves. But instead of survival over a study period, what we're looking at here is the amount of time that people spend uninsured. So at any given time, 1 month, 2 months, 3 months, et cetera, what percentage of people remain uninsured at that time? And so what we were able to do is leverage the health reform that happened in Massachusetts, which basically served as the blueprint for at least the coverage expansions of Obamacare, and look at what happened to the amount of time that people spent uninsured in other northeastern states that didn't implement a coverage expansion, and what happened in Massachusetts. And the basic story is that in Massachusetts, it dramatically shortened the amount of time that people were spending without insurance coverage, which is this difference in the graphs here. Another application of the small area toolkit we use to answer what seems like a kind of a weird question, which is what percentage of the people that are eligible for these marketplace plans have a bank account? And the reason this was important was because the way that the law was written and the way that the regulations were written were going to require that anybody signing up for one of these private insurance plans would have to pay their premium out of their bank account. And so this raised the natural question of, well, how many of these people actually have a bank account? They're low-income people. Maybe they don't even have a bank account that they could pay a premium out of. So maybe you're shutting people out of coverage simply because they don't have a bank account. And so for this study, I teamed up with Brian Hale and George Brandis, who are formerly at TenCare and then went to Jackson Hewitt, which is a tax prep firm. And we applied this small area methodology to basically, and we applied it to consumer data to answer this really basic question. And so you can see here on the bottom, there's very few things the federal government can turn around in 2 weeks. But when we published this study last year, about a year ago, within 2 weeks, the feds had rewritten the regulations to allow people to pay their premiums with other things like debit cards and things like that. So this is a really nice example, I think, of how you can disseminate research. This was just a policy brief, but it had a very lasting and fast impact on policy. Another application of this we published right after the Supreme Court decision on the Affordable Care Act. And the basic story here was that when the Affordable Care Act was being designed, the expectation was that every state would be expanding its Medicaid coverage to cover people basically up to the poverty line. And so with this expectation that all these low-income people that are currently receiving uncompensated care, that they would become insured under the Affordable Care Act, there's a kind of parallel scaling back of kind of side payments that the federal government was giving to hospitals to compensate them in some way for all the uncompensated care that they were giving to these low-income uninsured people. But the issue with the Supreme Court was that it basically made this Medicaid expansion optional for states. As you may know, Tennessee has decided, at least thus far, not to expand its Medicaid program. About half the states have expanded, half haven't. So what this meant was that all these reductions in uncompensated care payments to hospitals would go forward as if the expansion was happening. At the same time, you weren't expanding coverage to the very people that were receiving the uncompensated care. So it was putting hospitals in a huge pinch. And so we used this small area methodology to basically predict out at a state level what the implications would be if a state expanded or didn't expand Medicaid on their uncompensated care payments that they were receiving. So in the last few minutes here, I'm going to talk about how we should do workforce planning when we're about to cover 30 million new people in the United States. That is, do we have enough primary care providers, or are primary care providers maldistributed in certain areas, and we need to focus on those areas because they have a large population of uninsured people relative to the kind of primary care workforce around them. So if we want to go out and find shortages or in the primary care workforce, there's a whole federal agency that specializes in this. But if we want to kind of project that into the future to understand what the primary care workforce should look like under fundamental coverage expansion like we're seeing now, and as well fundamental changes in the delivery side of things, which I haven't even discussed at all in my talk here. But basically what we have to do is look at the utilization patterns that we see across the United States right now and figure out what those utilization patterns are going to be in the future. But at the same time all of these coverage expansions are going into effect, you have this whole parallel set of concurrent delivery system reforms that are basically trying to at least move us away from a fee-for-service-based reimbursement system and towards systems that focus on population health and pay-per-value. So there's real questions whether if we take the utilization patterns we've seen historically and project them out into the future as if they don't change at all, whether we're going to over-predict or overestimate the extent of shortages in certain areas. One of the other limitations that we found when doing this work was that the designation thresholds for designating a primary care shortage area, and to be clear, there's a lot of federal resources that go to these areas, so it's very important to distribute those resources accurately to areas that actually need them because they have very low capacity. But the designation thresholds that have been historically used to find these shortage areas are basically based on data, population-level data from 1974. And so, as I said, not adequately addressing these real challenges, methodological challenges, risks misappropriating resources to the wrong areas. So this is an example of what we've done in our work. So this is Autauga County, Alabama, which is actually the first county listed alphabetically if you go through a list of counties in the United States. So that's only to say that you don't have to go very far to find problems with all of these methodologies. So Autauga is adjacent to Montgomery, Alabama. And so if you take the kind of traditional method of designating shortage areas, what you do is basically take the an estimate of the total population and divide it by an estimate of the total number of providers in the area. And if that ratio is above 3,000, so if there's 3,000 people for every primary care provider, it's typically designated as a shortage area. So if you did that, in these three counties adjacent to Montgomery, Alabama, you might find that Elmore County, there in red, is a primary care shortage area. But if you look at the economic flows in this area, what you'd see is that about half the population in that county actually commutes into Montgomery County on a daily basis. So what we wanted to do in our work was basically create a better methodology for finding shortage areas. We want to kind of smooth out the estimates so that we aren't designating this county as a shortage area when it's clear that on a daily basis half their population is moving into a different county. The methodology itself basically constrains shortage areas and assumes that everybody only can access services in their own county when we know that's not the case. So what we did is apply what's known as a gravity model, which uses Newtonian physics, of all things. And we applied this across the United States using primary care physician data and population data across the United States and fit this gravity model. And like I said, it basically just smooths out these estimates. And we were able to use this to basically plot out in every county in the contiguous United States where capacity gaps might arise because of these coverage expansions. The blue areas are due to expansions of the private insurance marketplaces for people basically above poverty. And then the red areas are areas where if they expanded Medicaid, there could be some primary access concerns because there's a very large population of uninsured people who would be eligible for Medicaid. So again, this is basically where we are today, but I actually pulled a fast one on you. That cartoon is actually from 1965. Which is basically to say that we've had these concerns a lot. They're not new concerns. The difference now today is that we have the capabilities, methodologies, and data resources to bring to bear on all these policy issues of great importance to the United States moving forward. So I think I'll end with that.
show that
Yeah. Well, especially with these kind of primary care shortage areas, there's a lot of invested interest in that right now. You know, getting undesignated as a primary care shortage area could really impact areas. So, but in general, I mean, I found that most people in government have been pretty receptive to kind of data-based analyses. The trick is that disseminating it is there's an art to disseminating it, not being overly technical about it. And so, you know, there's a lot of focus in, you know, obviously as an academic, you want to be publishing in academic journals, et cetera. But there's a whole other element to getting your research disseminated to policymakers who are very receptive to it in terms of packaging it up for them. So I wouldn't necessarily say it's an underrepresentation. It's just there's a challenge as a researcher to think about how to make your work be most important to a policymaker.
Yeah, along those lines, your first year, the seasonal sign-up times, have you found receptiveness in the government to changing the season for sign-up?
So I think it's the case, you know, a lot of people, and I've talked to them about it, but they really need the evidence to point to justify moving an open enrollment period without appealing political. I mean, if it's very clear in the data that if you ask people to enroll between Thanksgiving and Christmas, they might not enroll. Just they've got a million other things to think about at the time. So this type of stuff, again, they're very receptive to it. I think there's definitely demand for it. Yes, though it's getting better. So one of the key things, and a lot of people here are dealing with this as well, is it's very hard to see at a kind of population level how people access the healthcare system. You can see here internally, we know if somebody's readmitted here, but we don't know if they're readmitted in another state, in another hospital, just down the road. There's real blind spots, and it's getting better. You know, a lot of insurers are starting to put out their data. They're more receptive to it, but that's been a clear challenge. You know, for our work is just getting a sense of a population and how they're accessing the system.
Okay, well, thank you very much.
Thanks.